The next presentation will be from CDC.
Thank you. It's a pleasure to speak to you this afternoon. I'm Greg Burrell. I am the Director of the Division of Strategic National Stockpile. This is a division of the Centers for Disease Control and Prevention, part of the Department of Health and Human Services. Today we want to talk to you about advancing public health and medical preparedness with operations research. So when you think about something called the Strategic National Stockpile, I imagine people envision the warehouse from Raiders of the Lost Ark. It's this just huge government thing with a bunch of stuff on the shelves. But the reality is the Strategic National Stockpile is about a lot more than just a bunch of stuff on shelves. The Strategic National Stockpile is a $4.7 billion valued repository of medical countermeasures designed to respond to all hazards. Primarily built around chemical, biological, radiological, and nuclear threats, we also have material to respond to pandemic influenza events and material that would be useful in other emerging infectious disease events. We develop and support state, local, and private sector capabilities, though, to be able to use that material. And this is where the real criticality of our work is. I can have everything in the world, but if nobody can use it, and nobody can use it effectively, it never mattered. So today we're preparing operations in the states and in the localities and with our private sector partners in a variety of ways. One of the ways that we do that is to leverage operations research capabilities. What we find today in public health, budgets are shrinking, staff is shrinking, staff moves around a lot. And for us, this is not about the commerciality of a product or anything of that nature. What we're trying to do is provide a capability so that when something bad happens, you're going to be taken care of. The only way that we can actually find out how things would work in one of these mass events that we hope to never really experience is to apply these powerful tools and techniques. The money's not there to do a full-scale exercise. In my business, what you normally do is do a full-scale exercise and actually test. We can't do that in these scenarios. Presidential Policy Directive 8 says that any response to these types of events, or really to any all-hazard event, has to be based on a whole-of-community response. It's not just the responsibility of the federal government. And we actually recognize that all responses begin locally. Then they move to the state level and then to the federal government. Private sector entities have a role in this, as do individuals. But there are challenges. So the objective here is to take a medical countermeasure that can respond to a health threat, to give that medical countermeasure in a short period of time to anybody in the United States who might need it. The challenges are obvious. We've talked about the declining base of operational funds at the state and local level. We've talked about the loss of staffing at the state and local level. And bottom line, we have a difficulty in measuring whether we even have the capacity across the country to do this work. So we've set for ourselves a benchmark challenge. And this benchmark challenge is based on an aerosolized anthrax event. In this type of an event, an enemy would release aerosolized anthrax spores into the environment. Inhalation of just a few of these spores within 48 hours will create flu-like symptoms. You will become ill. You will need advanced care in hospital settings. Care that hospitals are not capable of providing at the scale that we think may be necessary. The first thing we have to do is find out something happened, and then we have to decide what to do about that, and then we move forward to respond. But the window is so short, 48 hours, and I probably won't know when it happens to you that it happened to you. So we have to plan for it in advance. We have to be able to take a metropolitan statistical area the size of New York and hand every single person in that metropolitan statistical area in a very short window of time, possibly in 12 hours from the time we start, a pill or a bottle of pills to keep them okay. So historically, we took an approach to looking at this with other systems. And what we found is that the systems we were trying to leverage to tell us mathematically what was possible What our state and local partners could do and what we could do took too long to run. A basic principle of emergency management is you have to be flexible and you have to be able to change to meet emerging conditions in the field. So a model that takes 10 hours to return a result to try to allow us to change direction on the fly is just not useful. We tested this with an exercise in Arlington, and this was around a smallpox vaccination clinic. What this led us to was a partnership with Georgia Tech, and together we've created a suite of products that we call RealOpt. Today we're going to specifically focus on two pieces, RealOpt Regional and RealOpt Pod. And now we'll hear from Richard Besser, MD. Dr. Besser is well known. He was my former boss as the Director of Coordinating Office for Terrorism Preparedness and Emergency Response. He was the acting CDC Director during the response to H1N1, and he's a well-respected emergency management professional.
If a widespread outbreak of inhalation anthrax were to occur in your community tomorrow, would you be prepared to open and staff the numbers of points of dispensing or pods necessary to dispense antibiotics to everyone? Are you confident that you have designed your pods to operate at maximum effectiveness so that everyone in your community is served in the 48-hour window? How certain are you that you have made the right staffing decisions in your response plan? These questions are difficult because of the numerous responsibilities placed on emergency planners, but it's important to ourselves and our communities that we have the answers. However, answers don't come easily. During the pod design process, planners are frequently forced to take educated guesses on the best pod layout and staff distribution for dispensing. Until recently, they needed to conduct expensive and time-consuming exercises and drills to verify the accuracy of their guesses. While the only true test of our pod planning is an actual event, in today's program, we will discuss technology, computer-generated models that can simulate a real event, take into account some of the variables, and enhance the exercise process.
So what were our goals in developing this? Well, Rich just told you basically. But here's the bottom line. We have to prevent illness. We have to save as many lives as possible, and we have to do that using very scarce, limited resources in terms of time, labor, and finance. We want to make sure that we are making best use of state and local resources and federal resources to respond. We want to set the gold standard for operations performance in this area. And we want to provide for informed decision-making at all levels of government and provide for informed decision-making for the individuals in the public who have to understand what they need to do in these events. And I think we found our solution. Operations research offers us fast and robust optimization of scarce resources. It helps us figure out these hard questions, what some have termed these wicked problems, that we've got to have an answer to, that we can't do traditional exercises to find that answer to. And with that, I will introduce Dr. Eva Lee, who will speak to the work.
Thank you. So two of the systems that modules that we are going to talk about is RealOpt Pod, and that combines simulation and optimization into a seamless decision support system so that public health can actually use it for determining pod operations. And the second one is RealOpt Regional, where we advance the facility location problems and trying to solve these large-scale instances in seconds so that they can actually use it in the field and be able to respond. So a key part of the system development is really to design it so that it is very easy to our public health researchers to use it and operators to use it, because the volatile personnel there really requires to make sure somebody pick it up and they can just use it right there. So the roadmap of our work is that we are going to talk about the decision support system. We talk about the regional operations and strategic planning system, and how they intertwine with each other, as well as the dynamic reconfiguration capability, the disease propagation module within that, and then how we use that for responses to other hazards. So these are four-part point of dispensing, and I won't go through that in detail, just to show you that so you can see these are different type of biological agent that we are responding. There are similarities and differences, and we must get the best operations as well as the best assignments so that you have the best throughput. Keep in mind, best throughput means and translate to the amount of lives that you can save within a limited amount of time. So RealOpt regional is designed to facilitate strategic planning. Basically, if you're given a region, you have to determine how many pods to open, how do you route this citizen, and there are multiple objectives because operations costs you would like to be able to maintain at the constraint that you have to satisfy. At the same time, the citizens cannot travel too far away. So now let's look at this system and look at the Metro Atlanta, 5.2 million spread across 11 districts. And basically the task here is to analyze what is the trade-offs on setting up different facilities as well as how it impacts the operations. So everyone has to be assigned to a pod. There are physical constraints we must satisfy for each of the pod. That means the capacity, like fire code, parking space and everything. We must return a solution. Computationally, we all know so dearly for those optimizers is that there is the desire to have really key solutions at a very short time, and there's the desire to know where is the optimal solution, what is the optimal solution, how far are we from it. So the variables here, two set of variables, the assignment of the facilities and also the assignment of the population to each of these locations. So the left-hand side is the first problem that we have to solve, basically determining the minimum number of pod locations that we have to set up. So these are classical facility location problems that remain difficult. But what is difficult and hidden here that is very difficult to see is the value D max. Because of the heterogeneous density population across the city, D max actually is not a constant for the whole problem. It actually varies because for the very dense place, the distance could be very small. And for the widespread area, the density, the D max could be larger. So this is a variable, and it is very difficult to actually get that formulated properly. So what we do is we have a visualization tool that actually zoom in and show us all the density population. And then from there, we can determine those, the D max correctly and formulate that. Once we get that solution, we fit in into the right-hand side, and then we solve the assignment problem of the population. So the benchmark of this problem on CPLEX version 12, after a week of running on the problem 300,000 variables, is that you can see the lower bound and the upper bound is very far from each other. And this is actually a small instance that we are looking at. Now, our goal is clear. We want fast and good solution. Two of the things that we have to compromise maybe, but we do want to take that challenge. So we attack it using exact algorithms and also heuristic solution. We want to know the true solution. We also want a fast solution so that it will become useful. So the exact solution consists of the hypographic theory, and this has been the work that I've been working on since 2000, and because a lot of the cancer cases that I do is also very well-known facility location problem that is really difficult to solve. Here for an integer program, the hypergraph could be generated as follows, is that for each of the variable will correspond to a vertex of the graph, and the cover, the knapsack covers, correspond to the edges. Graphically, you can see it like the little note numbered are the vertices, and the edges are a whole bunch of nodes. And we have developed over the years quite a few polyhedral theorems against this type of hypergraph that is very high dimensional. So we call them hyperclicks, artholes, and web stars, and multi-stars. We have recently actually 2 new papers coming out. So these cuts are very difficult to implement. So the theory really goes far beyond the computation. On the other hand, we have great success on the prostate cancer instances, which is facility location problem. We have great successes with market share as well as classification, and we actually use this approach and really advance the theory and try to implement this. It takes about 1 CPU minute to implement 1 cut, so that is actually quite expensive. So on top of that, we would like to search for fast heuristic, and we've derived what we call the adaptive genetic algorithms. Here, the chromosome correspond to the set of facilities, potential facilities that we want to open. After mutation and also evolution, so we actually get a set of potential solutions, and then we remove the redundancy of the solution. Then we assign the population. Within the local search, there are 3 types of improvement: relocation, insertion, and switch. Switch is expensive, and so we do it judicially and just by doing it so that on the best solution so that we can improve the results. So out of the 2,900 instances from Metro Atlanta, the exact algorithms were able to solve all except 5 of them within 30 minutes. And within 15 minutes, it actually returns solution that is close to 5% of the optimal solution. So that's pretty good. Heuristic solutions beat it out. Within 50 seconds, it actually gets a solution that is as close to 8% of the optimal. So that is really great. And let me remind you, this is for real-time usage. And for emergency planner, they like to blink their eyes and then get the solution. So even 10 seconds sometimes could be quite long. And I'm sure if you sit in front of the computer, 2 minutes is a lifetime, right? It's like, come on, give me the solution. So that's really the challenge. We want them to be able to use it because we don't want them to just say, okay, let me guess it because the computer is not giving me a solution. So this is the efficient frontier showing the heuristic solution versus the optimal solutions of this. And so the planner could decide how many parts to open and the trade-offs. So if we overlay this solution into the city of Atlanta, so here you see the bigger the dots, the higher the throughput, hourly throughput. And then we also overlay the closed ports here. That means those sites that are not open to the public. So you have parts in the university, in large corporations, in the airport, and in assisted living, and also in the prisons. And then we also have mobile ports for those that need special assistance. So you can see that this is the dynamics. It is exactly the whole of the community is engaged in that whole process. So if we zoomed in, this is very interesting. I remember vividly this first time I showed this picture to all the local leaders at the CRI meeting. They stared at me and they said, wow, why are they so different? Because they said every site is trying to do 500 per hour. And you know that this cannot be possible because every site has different demographics. So this is precisely telling you how strategic planning is so important because it tells you exactly how to allocate resource properly. And that's very important. Now, if we look at the regional, this is how it works. You can draw the state, or you can actually just select it and then select the region that you are responsible for, load up those pod locations, and then you indicate whether it's a drive-through or walk-through. Then you optimize within seconds. It comes back with the solution. It tells you where they are, and it tells you how to assign the population. And then it tells you the demographics. If you have a large pediatric population, you need to be able to prepare for the worker so that they know how to actually design the vaccine, and they have to measure the weight and everything. So these are important because Rick is really good when we actually started. He told me there are sites that actually the demographics is such that many of the population that are coming in, they do not have the education like high school degree. So you will have to be prepared to really design forms or information to provide them with guidance so that they can actually really run through the process quickly in the pod. And that is not one size fits all. That's why we have to provide those information. Every site needs those. Now, after we get that, then we're going to look at the individual site and determine the resource that is needed. So I remember the public health likes to tell me that they are cash strap. They are not just cash strap. They are time strap, cash strap, and personal strap. They absolutely have not enough of just about anything, which is actually makes us feel really in the university we are very privileged because we always think we don't have enough. So now resource allocation is a challenge here. It's basically you want to say, I have a population I must serve. As Greg mentioned, over 90% of the population, if we don't give them medication for the anthrax response, they will die within 48 hours. So this is the real task that we must pick up and really march forward and be able to reach that goal. So given the population, you have to determine what is the resource you need. Or on the day of the event, you have only this amount of workforce that show up. What is the maximum throughput that you can actually process? So there are real constraints here. Is that we want to make sure the maximum queue length and wait time is not too long, and that the utilization of workers are even, so that they have good morale and they really give the best performance of the operations. You want to assign the workers appropriately so that they can actually do the work that they have to do, and you want to make sure the cycle time is not too long. Citizens really do worried. And the first event that I went to, we had one individual had heart attack during the process. The bus was lost. There were just everything that you can imagine. Can you imagine if it is a real event? There would be chaos if they stay inside too long and not knowing what's going on. Security officers really want them to get out ASAP, right? So that's important. So now lots of parameters. That is a nonlinear mixed integer programming correspond to that. The variable here is to assign the worker of different types into the workstation appropriately. And the cost function here corresponds to each station. We have the cost of assignment, the cost of waiting too long, the queue too long, and also the utilization. And then the cost of the whole system then consists of all these costs across the stations as well as the throughput and also the cycle time. So this is not a closed form, and we must obtain this through a simulation system. And this one basically constraint 1 and 2 correspond to the worker assignment. 3 is the set of characteristics that we want the systems to satisfy. This one CDC really punked me on day 1. So Jackie came and said, we must satisfy these because these are very important constraints. And they are real reason because they want us to make sure that the human behavior and all these are captured. And I really do appreciate that. And then we optimize the system. I know many of us, as an OR person, you have done a lot of these things and you know how difficult all these systems are. So to put them together, that is the important part, is that so basically input the model. It's just graphical tools that the user would draw the picture of the part. And then those will be translated automatically in the back end into the mathematical models. Then in the yellow box that you saw are the interplay between simulation and optimization. So we married the two of them. And then once they return a solution, then we actually assign the skill of the workers to the resource that is needed using a mean cost and network flow problem, and then simulate the system and generate the graphics and report the results to the user. So I'm going to walk you through the system. It's that there are two parts of it, and of course there are many different variations that you can see. First, you enter is that you initialize the number of workers that you assign to the blocks, and you compute the average total surface time and delay time. Then you simulate the system to obtain the system characteristics, and then you go and ask the first set of questions. Do they satisfy all the criteria that the user input? If not, you identify those blocks that violate that or the longest one, and then you optimize the system. And once you finish optimize, you go back to the simulation. So the first part of it you see is the intimate integration of the simulation and optimization together. So once that part is satisfied, you go to the second part is now you want to check are the average wait time satisfy what the users want? If not, then you identify those violated constraints, violated blocks, and then you optimize, and then you go back to the simulation. So the other half is, now let's not try to think about if the decision maker wants to have this solution within when they blink their eyes. That's really a very short period of time. I remember the first time the emergency director used it, you know, this is what he wants. And I really love it. I show him that, and he said, how long will it take? And then by the time he finished the sentence, it showed the results. And I think I got him, right? So, because if it took longer, if we actually spent 3 minutes to talk, I think we will be dead. So that is important, that part. So we also implemented the warm start here. We also implemented the warm start in the first step is we use the fluid model to put in the solution using analytic formulation and then put in that solution so that we can actually speed up the process faster. So here's the solution, and basically just show you contrasting 3 different parts designed. And this is critical. As you can see, they can see different type of workers they need as well as the different numbers that they need, and then they can make decision. Now, port is a place where if you don't have to go, you probably don't want to go there, right? If there's infectious disease, it is very important to determine what is the risk that citizens actually get infected when they come in, right? How do we control that? So sooner or later, this is really the part that everybody's going to think about. As we actually work with the emergency planner, epidemiologists actually came to us and said, well, look, now we want the tools also. Think about how do we deal with the disease predication. And here's the novel model that we have determined, and that works simple, really simple in a sense of design, but actually works really well. So instead of just looking at the standard SCIR model, we actually look at what if the patients actually do not show symptoms? They are infectious, but they don't show symptoms. What are we going to do? Are we going to have triage in the port, or are we not going to have triage? So in the front end, we basically allow them to actually select this 6-stage port, or the 6-stage disease modeling, or the 4-stage, or they can actually draw a picture and say, here's the disease modeling that I would like to use. In the back end, all right, I'm sure these are very small little equations that you're seeing. This is the ordinary differential equations correspond to the epidemiology model that they develop. So it translates automatically for them so that they can analyze it. And why do we need that? Because this is really important in terms of pod design so that we know and be able to do sensitive analysis for the scale of outbreaks and also ease of outbreaks. Should we use a superpod that actually run at 2,000 per hour, centralized, or should we use many decentralized small pods so that it actually really reduces the infection, right? So this is very important. And it allows the modeling of reinfection. It also allows infectivity modeling of the between the vaccinee and also the workers. The ultimate goal is really you want operations to be designed so that you understand what type of disease is being spread inside the pod and be able to mitigate it. So the key part here is really the first guy that I met in public health. He told me he doesn't know how to use the system like that he was given because he really had no clue how to start the program. And that was not my program. So I actually learned it is that in order for them to learn it and use it so that it's not like they have to actually take a class and take a course and get an A and be able to do it, is that we have to make it really easy and accessible for them. So we use a lot of the graphical user interface and translate all the drawings that they have using mouse click and then into the modeling language. And this is done for both the operations as well as for epidemiology. And this is important, as I mentioned, because you really want them to work together and be able to come up with the best operations. New York City is an interesting place. They have half the budget of CDC. New York alone, okay, it's a huge amount of money. So New York City is a lot more advanced than any other city in the United States. And also they have many part exercise and they have really try their best to do it. And so the New York City, in a sense, use RealOpt in a very interesting way. It's for decision and policy making. For example, they use RealOpt to determine, should I use express lane or should I just use my current one? Do I have enough personnel to actually support that? So they are not even thinking about like exercise. They're thinking about move forward the policy on how do you determine that. So they use the system, determine how many pods they have to use, and then they actually look at the throughput, how fast each of these has to move, and then they look at on the ground each of these, what type of design they can benefit from. What is the pediatric population? How do we design the pod in the best way? And then they determine all the populations and like serving that and what type of workers do they want. Strategically, New York City also have to worry about the translation and all this. And so we look at like, should they actually have a separate pod if half of the population coming into this pod actually speaks Spanish, like what is the trade-off, so they can actually look at that. And then they determine what is the number of personnel in each of it. I show you this is because 5 years ago, New York City was declared like not protectable in a sense that because they came up with 600 pods with more than 8,000 healthcare workers they need, and that was not possible for them to actually operate. So now they're very happy. Again, New York is leading the rest of the country in terms of decision making and all this, but it is really validating their idea. Like I say, it is very important. It really helps in different level. So Burnett Hicks is the emergency response manager of DeKalb County Board of Health in Georgia. He's also the co-chair of the City Readiness Initiative Planning Committee. So he's going to share with us some of the experience that he has, as well as like he basically reports some of the knowledge that he learned from the from RealOpt.
Hi, my name is Bernard Hicks. I am the Emergency Preparedness Manager for the DeKalb County Board of Health. I'm here to share with you the significance of RealOpt as it transforms our planning, execution efforts for pod operations. We served over 750,000 to 800,000 person population. 15 to 20% of that involves the city of Atlanta. DeKalb was selected in 2004 as the site to validate RealOpt capability because our planning efforts and capabilities were lacking behind the rest of the metro area and the country, and also at that time pod development and planning was also evolving. We were eager for such help at the time. We planned the 2005 full-scale anthrax antibiotics dispensing drill using RealOpt, from pod design to staffing and ground logistics. The result was phenomenal. It lifted us up to the top among all jurisdictions. We were the only site that surpassed the CDC required throughput, which was increased to 20-fold. And we used the least number of workers. The same year, we used it to manage 3,000 plus evacuees who fled from New Orleans due to Hurricane Katrina. RealOpt allowed us to manage our supply, provide food and services when we had no other extra staff to take care of the extra population. RealOpt is a powerful system that actually works. It predicts well. It provides good operations. RealOpt is not an Excel software like many of the others. It challenges us more in thinking of all the variables. It looks at the system and optimizes it. The results are remarkable. It predicts the operations flow as you see it on the ground, with such accuracy that we do not see in other systems. DeKalb is not the only jurisdiction that benefits from RealOpt usage. At S&S meetings, managers exchange thoughts of planning advances. One thing is evident. There are many RealOpt users out there that include cities all over the 50 states in the U.S., from large cities like New York, Los Angeles, Houston, to small and rural communities. New York City uses RealOpt in many levels of decision-making processes, from the ground operations to setting high-level important policies, because they have validated that it works, and thus its usage is so widespread that it includes setting of policies. Fairfax, Virginia. This county has over 1 million population. RealOpt usage reduced the number of staffing needs from 14,070 to 5,226. Interesting, they also evaluated how long it took them to train. Without RealOpt, it took 2 years. Utilizing RealOpt, it took 9 months. Washington, D.C., a strategic city to protect with 600,000 residents and 1.2 million daytime population. RealOpt Regional was used to identify 16 pods and determine whether drive-through or walk-through was most conducive. Within months, law enforcement and planners are able to start their operational planning instead of taking 2 years to figure out where to put the pods strategically for maximum coverage. Connecticut Eastern Highland Health District. Using RealOpt, in less than a month, they mounted a very successful H1N1 mass dispensing campaign. The city of Houston has over 2.2 million residents. They use RealOpt for anthrax planning and actual flu vaccination and pandemic preparedness. They saw a great gain in throughput and operational efficiency. They even used it for human commodity points of distribution as it recovered from Hurricane Ike. It is not possible to summarize all the great things that RealOpt helps to accomplish across the whole country. It truly transforms our planning, and it takes the best out of the planners across the country. Optimal operations, layout design, throughput, staffing, bottlenecks, decision and policy making, and training. It saves lives, money, and time. This is materialized in peaceful time for H1N1, hurricanes, and so forth. For terrorism, the impact is far beyond our imagination. It was not easy for a university professor to invade our territory. We resisted. We wanted to do it our way. A few years back, when we first met Dr. Lee, we told her we were trying to get to 500 throughput per hour for anthrax and antibiotic dispensing. We were not there and didn't know how to get there. She asked, why only 500? Now we're talking about 2,000 per hour. We even use fewer staff now, thanks to RealOpt. CDC, let us choose what we want to use, but clearly, we know what we want to protect the largest population possible within all the constraints.
So what you saw is that Bernie has summarized some of the testimonies from users, and we have also done an objective analysis for 12 sites, and these basically we see they use fewer staff, and also they improve their throughput by quite a few factors. So the key part is really going back to how well can we do. This is a comparison of the usage of different systems, and like how do we actually affect a population of 750,000 people. And you can see that using RealOpt assignment, it actually reduced mortality by a big number, and this is really very critical, and the black lines are the mortality rate. So the usage is widely adopted, and it's being picked up by many different agencies and also outside the United States. And 4 major advances. First is really the simulation and optimization systems that allows one to actually model the complex systems and including the human behavior, and that it creates a system that is more seamless and more powerful that you can actually use for decision process. And the second one is optimization. In terms of the computation side, we were able to solve these very difficult problems within seconds, and also using simulation to guide the optimizations, we're able to give the pod planner a very good tools in which they can actually determine the operations on the ground. So the cognitive part cannot be really emphasized enough, because a system that is not used is not really useful in terms of like really being able to impact the field and also assist the public health responders. So this part is very critical, and we actually spend a lot of time in that. And the last part is that IP is always being influenced by applications, and this is a classic example where the theoretical results is being pushed on by the applications that we see.
We want to show you quickly CDC's nationwide broadcast on mass antibiotic dispensing, taking the guesswork out of pod design. This is being spoken to by Dr. Linda Neff, a very senior epidemiologist with CDC and highly respected in this field.
Now, Dr. Neff, the RealOpt model sounds a bit more complicated than the other 2 models.
It sounds that way, Joe, but it's still easy to use. Just like the other 2 models, RealOpt is user-friendly. What's different about RealOpt is that it currently offers you 8 real-world pod and clinic examples, such as a drive-through pod or non-segmented pods where patients are brought to the pod site in buses. All the data for these pod designs were taken from exercises monitored by Georgia Tech students and faculty. These 8 examples can be modified to meet the needs of your pod plans, or you can enter your own design. RealOpt runs a calculation to figure out how many people should be assigned to each station. It also helps define the skill level required for each station, and it may be useful in reassigning staff should your available staff change. While it gives you more freedom, it also requires more work. There are more user inputs in this model than either the BERM or the clinic planning model generator, but this also gives you more flexibility. RealOpt assumes that people will arrive at the pod at various rates and not in a steady stream. The real difference between this model and the other 2 is that RealOpt has a graphic display showing the patient flow patterns in the pod. This graphic display allows you to add, move, or delete stations in the pod with the click of your mouse. Another thing I'd like to point out about this model is that it runs on Java, and it can be downloaded and run on your personal digital assistant, like a BlackBerry or other handheld device.
Okay, I've got a follow-up for you here. Now, do these models account for population surges and slower times throughout the campaign?
The models that we looked at today all assume, except for one, the RealOpt, assumes a steady state or steady rate of population attendance at the pod. The RealOpt is a little more flexible and allows the user to put in parameters that would look at the impact on the pod for with the different ebb and flow of population attendance.
The benefits are huge, but here's the main thing. This prevents illnesses and it saves lives. And as you consider this, consider where you are sitting today is a place where this is being implemented, and I believe if there's something happened to us today here would result in us being saved. It's adopted widely. 4,000 plus user sites. This is not numbers of users, this is sites using this. Not only public health, but our private sector partners. It's been used in hundreds of drills and exercises. There are many qualitative impacts on national health security and emergency response capability. Quality assurance and training is much better for our staff with this than it ever has been before, and for the public health staff that you will rely on across the nation to save you in one of these events. The quality of service is improved, worker morale has improved, we're not overworking anybody, we're not underworking anybody, we're keeping things at the right level.
CDC firmly believes that computer simulation and modeling technology are extremely valuable in many areas of public health. Modeling has already been adopted and proven effective in improving efficiencies across a wide range of functions, and it's now clear to us that the integration of this capability with public health preparedness is essential in building the public health infrastructure of tomorrow. Ultimately, pod modeling may assist you in your efforts to save lives and prevent illness.
So on behalf of public health, I thank you for giving us this opportunity today to spread more about our message and our needs and the importance of the work that our people do. We will continue to apply operations research to improve our capability to protect you, the American public, to all of our great nation, to assure that we're safe now and in the future. Thank you very much.